Thank you, everyone. So good afternoon, and thank you for joining us today for the inaugural Diane Fairclough Distinguished Lectureship. My name is Katie Colborn. I'm an associate professor in the Department of Medicine, and I lead the Biostatistics and Analytics Core at the Adult and Child Center for Outcomes Research and Delivery Science. As one of Diane's mentees, I'm truly honored to have the opportunity to introduce our distinguished presenter, Dr. Melanie Bell. Before I introduce you all to Dr. Bell, I want to say a few words about Diane. So we're proud to recognize and celebrate the life and legacy of our colleague, Diane Fairclough. Today, through this visiting professorship, which is supported by the Colorado School of Public Health, Department of Biostatistics and Informatics, the Center for Innovative Design and Analysis, and Accords. Diane's journey into public health was sparked by a powerful encounter during high school that inspired her to enter the medical field. Though she initially aspired to become a physician, she found her true calling in research, where her work would ultimately have a profound and lasting impact. Even as she faced her own cancer diagnoses, Diane's empathy and strength only deepened her commitment to improving the lives of others, especially those living with cancer. With advanced degrees in public health and biostatistics, Diane went on to serve some of the nation's most respected institutions, including St. Jude Children's Research Hospital, Dana-Farber Cancer Institute, and here at the University of Colorado Anschutz Medical Campus. It was at the School of Public Health and Accords where Diane became a pioneering researcher and beloved mentor, known for her work in clinical research, patient-reported outcomes, and statistical methodology. Her many contributions to these fields earned her national and international acclaim, including recognition from the International Society for Quality of Life Research. And beyond her accolades, Diane is remembered for the generosity of spirit with which she guided colleagues and students alike. In addition, we'd like to acknowledge Diane's sister, Suzanne, who established an endowed fund in Diane's memory. It will be an enduring tribute to a remarkable individual whose life was defined by compassion, resilience, and relentless pursuit of knowledge in service to others. Though this visiting professorship and the Fairclough Endowed Fund, through these funds, we honor Diane's extraordinary life and carry forward her commitment to rigorous scholarship, compassionate mentorship, and meaningful impact in public health. And also thanks to this endowment and commitments from the School of Public Health, CETA, and Accords, we are grateful to welcome Dr. Melanie Bell today. Dr. Bell was one of Diane's most cherished mentees, and our committee unanimously agreed that she was the most appropriate inaugural guest to honor today. Dr. Bell graduated with a PhD in biostatistics from the University of Colorado Health Sciences Center in 2002. And at breakfast this morning, she commented on our improved surroundings compared to the 9th and Colorado campus where she graduated. After graduation, she spent 7 years in New Zealand and was tenured faculty at the University of Otago. Subsequently, she worked at the University of Sydney in Australia before being recruited to the University of Arizona, where she spent the remainder of her career. She's currently Professor Emeritus in the Department of Epidemiology and Biostatistics at the Mel and Enid Zuckerberg College of Public Health. Her research focuses in methods for handling missing data and intervention in cluster randomized trials, patient-reported outcomes, and research methods evaluation. Her past collaborative research was in the fields of cancer, tobacco cessation, psycho-oncology, cardiovascular disease prevention, and health inequalities. She has nearly 200 publications, and perhaps one of her most notable accomplishments she shared with me this morning was that she graduated the first PhD student from the Department of Biostatistics at the University of Arizona. Dr. Bell, it's an honor to have you today. Please join me in welcoming Dr. Bell.
Thank you so much. I just cannot tell you what an honor it is for me to have been invited to this talk. It's great to see everyone here in Colorado, and also just to have thought through some really wonderful memories of Diane. So my plan today is to discuss some of her research and how it intersected with and influenced my own. And I also wanted to give some indication of the impact that Diane has had, the very large impact that she has had on the field of quality of life research and patient. First, I do want to make a few acknowledgments, in particular, Suzanne Fairclough, Diane's sister, who is here with us today, right? Gave me a lot of help. She provided photos and she gave me a lot of excellent information. And then thank you to everyone else who shared stories about Diane. And there were a lot more this morning, and I thank you all for that. So Diane started out in chemistry, got a bachelor's and a master's in chemistry, and then eventually saw the light and biostatistics. And she did that at the University of North Carolina. As mentioned before, there were some formative events that really turned Diane into the person she is. Was working on her master's degree at Virginia Technic when she was diagnosed with Hodgkin's lymphoma, and then later received diagnoses of melanoma and breast cancer. I remember her telling me that when she was getting chemotherapy for her breast cancer, it was great because she had so much uninterrupted time to sit and answer all of her emails. The woman, you know, she was devoted, and she also found time where she could. So clearly her multiple bouts of cancer informed much of her research, and it was for her becoming a leader in quality of life research. As mentioned, she was very involved with the International Society of Quality of Life. She was the president from 2009 to 2010. Here's a photo at one of the annual meetings in 2008 in Uruguay. She received the President's Award for her work on behalf of the society. One of the last times that I saw her was in 2019 when I was at an ISAQOL meeting. She was talking about the chemotherapy-induced neuropathy that she had in her feet and how informative that was for her to be on both sides of the data. Diane was certainly a research powerhouse. Her book, The Design and Analysis of Quality of Life Studies in Clinical Trials, has been cited over 850 times. I myself have made 3 international moves, and I got rid of a lot of stuff, but I never got rid of this book. It was always in the keep pile. She contributed to 18 other books. She published more than 250 papers in both the methodological and clinical literature, and she had an H index of 100, which means that she had 100 papers that had been cited more than 100 times, and that's quite an accomplishment. I reached out to one of her longtime colleagues, David Sella from Northwestern, and he wrote back a lovely email. He said, I met Diane in early 1991 while she was working at ECOG. Over the ensuing 25 years, we published 17 articles and 13 abstracts together on topics ranging from handling non-ignorable missing data to psychometrics and clinical trial outcome reporting. But there were 2 quotes that I really loved from Dr. Sella. Diane kept us grounded in truth. And I think that that probably rings true to a lot of you who worked with Diane, that she made sure that you weren't overstepping what you could say with those data. And then he said, the essence of Diane is that she was a passionate, caring person with a huge heart. who every once in a while like to kick up some fun, which I think is exemplified by this photo. Diane worked at the University of Tennessee, Harvard School of Public Health, and the University of Colorado for 28 years. She was one of my professors and fantastic. So a little bit about my own history. So I graduated under the supervision of Gary. I think Gary just barely beat me into retirement, I think, or I might have beat him. Same day. At that point, my PhD topic was replicated spatial point patterns. For those of, if there are any students in here, I just want to let you know that just because you do your PhD in a certain topic doesn't mean that you're stuck in that forever. Because I didn't do spatial statistics for many, many years. But I did take a class on longitudinal analysis and missing data from Diane in 2001. All right. Who are these people? Okay, the first one. Dick Jones, that's right. And then we have Anna Barone, who is also here today. There's myself and Gary. Does anyone recognize the person kind of behind Anna? Yes, David Weizenkamp. And then I have no idea who that last person is behind Anna. Okay. Then I went on to the University of Otago, and my first position was there at in Dunedin, New Zealand. And does anyone know who this photo is? John Kittleson. Yes. So John Kittleson came down for a visit, and we visited the Lost Gypsy Art and Automata Gallery in Papatawai on the South Island of Newfoundland. So I essentially took John's position at the lovely University of Otago and here it is on a rare sunny day. And that place, rough on a person that grew up in Arizona and Colorado. So my next position was at the University of Sydney with the psycho-oncology research group. And I'm pretty sure that the reason I got the job was stating that I had a class in missing data with applications in quality of life with the famous Diane Fairclough. They said, oh, yes, okay, we will be offering you the job. So POCOG was one of 14 trials groups that were sponsored by Cancer Australia. And I worked with Madeline King, the Cancer Australia Quality of Life Chair, and Phyllis Buteau, the head of POCOG. So the mission of POCOG was to develop and facilitate interventions and services that optimize psychosocial and supportive care. So when I applied for this job, I just kept thinking, I am so glad I took that class from Diane, because this is going to be so useful, and it was. So some of the studies that I worked on while at POCOG was a longitudinal study, observational study on ovarian cancer, cancer in culture and language diverse people, fear of cancer recurrence, a trial on advanced care planning, a couple trials on cognitive impairment following chemotherapy. So quality of life was an outcome for each of these trials. And as you might imagine, data was always an issue. So just in case you are not super familiar with the bias that can occur with missing data, here's a graph from one of those studies, the Australian ovarian cancer study. Now, this graph is stratified by the number of assessments. What we're seeing here is quality of life. And the pattern that you see here is that people who didn't have very many assessments started out worse. And in some cases, they seem to have sharper decline as well. So clearly, we do not have data that are missing completely. But suppose that we did a complete case analysis, or a last observation carried forward, or a mean imputation. You can see just the kind of bias that we would get. You would say, all right, looks like ovarian cancer, not that big of a deal. Who do you suppose these people are? Early stage. Yep. Yep. Early stage. And survivors. All right. So when I was at POCOG, a senior cancer trial statistician asked me about differential dropout. And this made me realize that many researchers, even really experienced ones, had some misconceptions about differential dropout. And I decided it was time for some myth busting. So the first myth is that if dropout rates in longitudinal clinical trials are similar between study arms, your results will be unbiased. You don't have to worry. This is not true. The second myth that I wanted to bust was that if dropout rates are unequal between the study arms, then your results will necessarily be biased. This is also not true. So I went ahead and ran a few simulations, and I said, all right, yeah, I think this is a good paper that needs to get out there. So I recruited Diane and a couple of other folks, Michael Kenward and Nick Horton. Those should be familiar names to some of you. Nick Horton is the vice president of the ASA right now, and Mike Kenward, we use his degree of freedom all the time, right? And again, to junior professors and to students, I'm just going to say, someone once asked me, how is it that you've managed to publish with some of these really famous statisticians? And I just asked. So consider that as a strategy for yourself too. And it was great to be able to publish in the BMJ in their research methods and reporting, because this has been a highly cited paper. Okay, so this is the one paper that the one piece of research that I'm actually going to talk about in depth. So although Diane and I have written several papers together. So what matters statistically is the type of missingness and the type of analysis. And depending on those factors, you can get biased estimates with equal dropout rates or unbiased estimates with unequal dropout rates. So if you don't know what those acronyms are, here's a quick definition. Outcome data are missing completely at random if there are no systematic differences between values that are observed and missing. Data are missing at random if after taking account of observed outcomes in covariates, so this might be in some kind of model, like a weighting model or an imputation model or just as covariates, there are no systematic differences between observed and missing outcome values. And finally, data missing not at random are those whose missingness depends on the value of the data itself, even after taking account of the observed data. So a lot of times people will say, well, how do I know which kind I have? I say, well, you can't ever tell whether you have missing not at random data, because by definition, those data are missing. So the only thing we can do is do simulation studies and enforce what kind of mechanism. Okay, so what also matters is the analysis. Oh, and by the way, in practice, missing data are generally a combination of all three. So anyway, what works and what doesn't. So complete case analysis and simple imputation methods are biased when data are not missing completely at random. But even if your data are MCAR, the last observation carried forward can yield very biased estimates. And you saw that with that ovarian cancer data, how that is a really bad assumption to make. And when data are missing completely at random or missing at random, multiple imputation and weighted models and maximum likelihood models yield unbiased results. And I guess I should say, because Ed Bedrick was faculty here for a little while, you can use Bayesian methods too. So I did a simulation study, a 2-arm RCT with 3 time points and a sample size of 200. I had 2 data patterns, both with a treatment effect of 5 points on a 100-point scale. I varied the type of missingness, the rates of dropout, so I had equal and unequal dropout. And I changed around the missingness mechanism. So the same direction missingness mechanism was that both control and treatment arms were more likely to drop out worse quality of life scores. And then different directions is that it went opposite each other. So the control arm was more likely to drop out with worse scores. These were my simulated data patterns, and they both have that 5-point change or 5-point difference between the arms. This was a simulation model. I'm not going to go through that in depth because someone once told me you should never integrate in public. Gary? All right, so the analysis that I did kind of a naive analysis which is mainly what is used. And then I used likelihood-based methods. So t-test with complete case analysis, imputation using the mean of the individual's previously observed data, and the last observation carried forward. And then I used a mixed model for repeated measures. That is an unstructured time and covariance, meaning that it's can take any profile that you want, and it'll accept that temporary change that we saw with that one pattern quite well. All right, so here's the results. So myth 1 has been refuted. Equal dropout rates do not guarantee unbiased results. We see this that with one of those naive methods, we had biased estimates for many of our scenarios, up to 60% bias for a complete case analysis when we had different directions. Interestingly, the complete case was unbiased for equal dropout in a missing at random situation. And it was unbiased also for a missing completely at random for the complete case, which is what we would expect, right? But last observation carried forward, which a lot of people use. So even under the very strong assumption of missing completely random, you still get pretty biased results. Okay, so then I refute myth 2, showing that unequal dropout rates does not imply biased results. You see that we have biased results for everything except for the maximum likelihood-based model, the mixed model for repeated measures. So you might be wondering, what did we find out with the missing not at random? Everything was biased, as you would expect there too. What should you do in that case? Well, first of all, you don't know that you have that case, but you should do sensitivity analyses. And Diane was very big on that. Okay, so this paper to me was a real attempt at knowledge translation or implementation science. Okay, so a lot of other fields have talked about this, but I don't hear it get talked much about in statistics and biostatistics. We write these theoretical papers, they get published in statistics in medicine or biometrics, and they only get cited by other papers in those journals, right? But sometimes it would be really great if we could get some of these more robust methods into the general research arena. So publishing in non-statistics journals like the BMJ can help in translating results. Education and communication are definitely key, as is software. Okay. By the way, I'm just going to say that this was a challenge to write this paper for the BMJ. They kept one of the first reviewers thought that the simulation study was an actual trial and was wondering where my table 1 was. And then through various rounds of revisions, I just kept putting more and more of the math into the appendix. But that's okay. It's there. It's in the appendix. Like I said, it gets cited a lot, and it's getting translated. So the reason I wanted to talk about this particular piece of research is because I know that Diane wanted her research to be used. She was really good at translation. She provided software code in SAS, R, and SPSS in her books. And that's amazing that she was able to do all of that. She also taught workshops internationally, including one with me in Sydney in 2012. And there's a giant concrete koala bear. And there's some kangaroos and a wombat. So some further collaboration with Diane. At some point, she asked me if I wanted to co-author an invited paper on missing data in patient-reported outcomes in statistical methods in medical research. And the way she phrased it, do you want to be a big fish in a small pond? And I said, yeah, I do. And actually, I was really, really grateful for the opportunity and the mentorship. It meant a lot to me. And I'm just going to take an aside before I talk about that paper to mention mentorship, because that is something that has just come up over and over and over again while preparing for this talk, as well as today. So her CV listed 10 K awards. That's a lot. And I found that she didn't bother to list grad students, probably because she just had too many. Rita, who I went to grad school with, said, my best memories of her are sitting on her back porch and going through my list of stats questions for my thesis with her. She was so generous with her time, as I think. JC told me at our courts meetings that she admonished junior professors to practice saying no to service. And that's a wonderful thing to help, like not to give those junior professors the boring service that you don't want yourself, but to take it on so that they can work on developing their own research careers. A good friend of mine who has a statistical consulting company in Tucson and in England, and who specializes in patient-reported outcomes for pharmaceuticals, Stacy Hudgens. She said, she is one of the giants who mentored, validated, and made me feel so good about my research path, and I even tear up writing this. And I think that a few people teared up today just thinking about just the selflessness that Diane, with her time that Diane gave to all of us. So this is the paper that helped me become a big fish in a little pond in statistical methods in medical research, and it's a highly cited paper as well. The last time I checked, it was about 350 citations. And so it's great that it's getting out there. You'll notice the practical, the word practical is the very first word in the title. So I'm going to very quickly discuss this paper. There was a lot to this paper, but we did show an example with RCT and renal cell carcinoma. There was about 200 patients. We had 6 time points, and by the 4th time point or assessment at 17 weeks, only 43% of surviving patients had complete quality of life data. So the trial used the FACT-G trial outcome index, a sum of the physical and functional well-being scores, and some disease-specific items. So the estimate of interest was the mean difference in quality of life at the 4th time point using, and we went ahead and looked at various approaches to see what kind of variation we would see in those estimates. First, here's one of those graphs stratified by time of dropout and by arm. And again, you see that similar pattern of people with worse quality of life to begin with are more likely to drop out or die, particularly here in the experimental arm on the right. So we did several different approaches: t-tests and ANCOVA, generalized estimating equations, GEE with a polynomial function with continuous time, the mixed model for repeated measures, mixed models with polynomial growth curve, multiple imputation, weighted GEE. And again, I'm not going to get deep into this, but I think that this comparison is pretty telling. So take a look at that first column of the estimates. And you'll note that the difference in quality of life ranges from negative 0.36 to 15.4. So, or negative 15.4. So that's massive. Also, you should note that the standard errors are widely variable, and therefore the p-values as well. So it really does matter what you use, especially when you have a high amount of missing data like we did in this trial. So really, one of Diane's things was that she emphasized over and over again, it's best to prevent missing data. And because anything we do analytically is never going to be as good as if we had just gotten the data. You should always pre-specify your analysis plan, and you should include sensitivity analyses that vary missing data assumptions. And more recently, and recently in terms of statistics, the ICH-E9R1 has come out, and that stands for the International Committee on Harmonization, and they are really pushing an estimand framework. My own thoughts on this are that people are already struggling with actually defining the term ITT correctly, and so the estimand framework has the potential to really muddy some waters. In the grants that I'm still reviewing for the Cystic Fibrosis Foundation, I actually am not seeing anyone use these terms of the estimand framework. I still think it's a good framework, but I think that caution needs to be taken with that. All right. We also published a few other papers with Madeline King, who we worked with in Sydney. Again, mainly to do with missing data. And but like many other biostatisticians, she worked on a wide range of fields. That's the one wonderful thing about being or one of the many wonderful things about being a biostatistician. She worked in oncology, pediatrics, and as well as end-of-life and palliative care. She, in the field of quality of life and patient-reported outcomes, she worked on psychometrics, meaningful change, as well as her very strong work in handling missing data. In the last few years, though, she kind of pivoted and started working in the field of stepped wedge trials, which I found quite interesting because I think it's a pretty interesting design. It's a one-way crossover cluster randomized trial, and where the period of crossover is what's randomized. I actually wrote one grant that used this design, and I was relieved when we didn't get funded because they're complicated. They're really complicated. Anyway, this is a fantastic paper that she wrote with a student and with Miriam Dickinson. And here it was the example that was used, a decision aid for patients with heart failure, where there were 6 sites. You can see that each one of the sites eventually will get the treatment, if not every patient, but each one of the sites will. So again, the time that crossover from control to treatment is what's randomized. As I mentioned, I was relieved when I didn't get that grant because it's complicated. But it wouldn't have been so complicated if I had had Diane's feasibility checklist. So this is the paper that I believe she was working on before she passed away. And it's just so practical and useful. And I think it really, again, this gets back to that whole implementation science and knowledge translation that Diane was all about. So can all sites begin at the same time? Are they all likely to complete? Are there similar accrual across sites? Is the participant pool large enough to avoid selection bias over time, et cetera? Again, this would have been so useful for me when I was writing that grant, when there were really only a few theoretical papers out about this particular design. I hope someone that has worked with her can maybe take up the mantle and write this paper, because I think it would be very useful and probably highly cited. So that's kind of the end of my statistical talk. I did want to just go through a few things that were important to Diane. Some of these have already been touched on, but Diane loved to hike. She hiked all over the world, and a real passion. Some of you might recognize this dog. This is Sam, and she was very, very fond of dogs. She fostered dogs and got them ready for adoption, which is so sweet and giving. And I'm thinking that this is in the famous backyard of Diane. She loved Hawaii. Really loved Hawaii. She went there all the time. And one of the things she loved to do in Hawaii was play ukulele. And this was a real passion for her. I caught her once, I believe, when she was not loving work, as we all do sometimes. And she said, I just want to retire and play the ukulele full time. And here she is with her sister in Hawaii. Here she is playing, I believe, the recorder. I'm guessing that's also in Hawaii. Miriam told me that Diane plays the bassoon as well. So that was something I didn't know, and I'm quite impressed at that. Here she is playing with the Swallow Hill Music here in Denver. And I think a lot of us knew that gardening was very important to Diane. Here she is volunteering at the National Botanic Gardens in Hawaii. And I also know that when we were scheduling our workshop in Sydney, that it had to be scheduled around tomato season in Denver. And I just want to finish with a photo of Diane when she realized she wanted to grow up and be a biostatistician. All right, so thanks very much. Again, it's been such a pleasure to write this talk and to come here, and I would welcome any comments or questions at this point.
About whether about equal versus unequal. You talked about the bias, but did you also investigate the effects on the variance and whether you correctly captured the true variability with the different methods?
We did not, but I can imagine that that could be a bit of an issue as well. Definitely those single imputation methods, they're always going to give you too small of a variance. And
Right.
so,
Even if they are unbiased, say you'll probably be underestimating variability.
yes. Yeah. Other questions?
Does this work? I have a missing data question, but I just wanted to thank you for coming and also just to, remember Diane fondly and for all of her time that she gave me as a mentor and other people. And, just thinking of how it's mediated through other people too. So, any mentorship she provided to me is now being provided to other junior investigators. So even though I had the missing data question, I don't want to lose sight of that in this talk. So my missing data question is, whenever I write a grant, I say exactly what you said, where if I have missing data and if I have evidence that there's differential dropout or something like that, I just propose a bunch of sensitivity analyses. And then I get to the point where I'm analyzing data and I realize that sensitivity analyses are huge and I'm never quite sure when I've done enough sensitivity analyses or what the right sensitivity analyses are or what I should do when my sensitivity analyses don't agree with my primary approach or with one another. So I don't know if you have any thoughts on that issue.
It's hard. My own approach is to try to pre-specify as much as possible the sensitivity analyses that I'm going to do. But sometimes it happens that you have sensitivity analyses, the results don't really match with your primary analyses. And you have to acknowledge that and within the discussion and conclusion say, this is what we found, but we're not 100% confident about it. And I know that researchers hate that. They hate statisticians saying there's uncertainty here. But it's true, and we have to be grounded in truth, right? So some sensitivity analyses that I really like are missing not at random multiple imputation. So say tipping point, like at what point, if you just add on certain values to your outcome, or to your effect of interest, at what point does it tip from significance to non-significance. Oh, at this point, well, that's not probably ever going to happen. So I think we're fairly confident that we have a statistically significant result in this area. I also like control-based imputation. Like, all right, so if these people dropped out and they weren't getting the treatment anymore, I don't think it's a bad assumption to think that they might act like the control group. So, and that is becoming implemented in various software. So it's not going to take you months to write yourself. That help?
Yeah, it does. I think it just affirms that I'm not the only one that finds it difficult, at least, too.
Again, what's difficult, I find, is that when I write a thoughtful sensitivity analysis result, that I get pushback from the co-authors or even journal reviewers. But I guess that comes back to that we have to keep with the knowledge translation and of trying to get better statistical methods out there and more rigorous methods. Yes.
I think it was interesting that you mentioned that the estimand framework is, you don't care for it. Well, in other words, of that because it's confusing and it muddies the waters to a certain extent. What I wanted to comment on and ask the question is that with the FDA has been requiring that for almost 10 years now. And what are your thoughts on that? Does that muddy the waters there as well? Or is that such a different environment that there's clarity there?
I think that's a great question. And I was following what was going on with the FDA and the pharmaceutical companies, because you go to JSM and there's a lot of talks on the estimand framework. And but then no one I ever worked with ever wanted to talk about estimand. And when I tried to talk to them about it, it completely went over their head. So that's what I mean about, like, it's not a simple, there's not a simple conclusion. That's why I retired. But I mean, what are your thoughts?
I agree. Some very high level biostatisticians within the pharmaceutical industry I saw really working on it and trying to translate it to everyone else. But it is hard to wrap your head around. Yes, I agree.
Some of the causal modeling for some of those estimands, I think, is going to be a bridge too far for a lot of researchers, for example.
And if you think about the the protocols on clinicaltrials.gov and the results and how they're interpreted, I mean, it's almost not clear what your outcomes are anymore.
Right. I agree.
I have to share how in Accords, Alley Camp is famous with hosting Thanksgiving dinner, and Diane is equally famous with taking the turkey leftovers and every day bringing us turkey and rice soup the next day. So we have to, it just speaks to, I think, her generosity of spirit, and she just, for all of us, it just appeared the next day. We would forget about it, and it was like so lovely to have her soup that she brought. And she'd bring it in huge pots for all of us to share the day after our Thanksgiving celebration.
I have a question. So thanks so much. I'm a non-statistician, and like Diane, you model really being able to share about a topic that I can follow as a non-statistician. I think Diane did that so well. She also really excelled at mentorship, which I appreciate that you highlighted, and she really excelled at mentoring across different disciplines, as all statisticians need to do. I wonder if you can share any tips that she modeled or gave you in terms of giving you insights for how to have successful collaborations in team science.